Good morning, one and all. Welcome to our classroom series. Today we have Dr. Megha. She's a specialty doctor practicing critical care in Royal Stoke University in the United Kingdom. Ma'am is going to discuss about the delirium management and the neurointensive care. Over to you, ma'am.
Yeah. Can you hear me?
Yes, ma'am. You're audible.
Thank you. Good morning. Well, it's good morning in the UK. Uh, uh, Thanks to Dr. Sindhu and Dr. Ponea for giving me this opportunity to do a session teaching. The topic here I'm going to do is so it is about confusion in ICU, and it is a confusing topic. I would try to touch upon the base as far as possible. I don't have any declarations to make, I don't have any conflicts of interest. But before I start, it is about management when we are dealing in neurointensive care. However, most of the studies, when you look at in literature, which are done on delirium, they are done in general ICU patients, and whatever we use in neurointensive care is largely a reciprocation of the data which we have collected in general ICU. I currently work in a mixed ICU setting, so I tend to see both sides of patients, have used both pharmacological and non pharmacological management. Um, so, whatever I'm going to say now from here on, I think whatever settings you're working in, probably everything needs to be tailored according to your subset of patients, and there's no size fit all strategy here. So it is why I've put this slide as the first one, is to reaffirm and reiterate the fact that delirium is an organ failure. It is a sign of an organ dysfunction. So it is as much important as we deal with acute kidney injury or acute liver failure or acute respiratory failure in an ICU. However, unfortunately, it doesn't get that much of interest, and it's often overlooked upon as, okay, maybe the patient's agitated, is it withdrawal, and the patients do carry on. However, the last thing in an ICU, what we would want is treating a patient for a traumatic brain injury or treating a patient for stroke, but then patient ends up in a delirium and has a prolonged ICU stay, acquires an ICU infection, possibly, unfortunately, dies because of that. So that's the last thing you would want to see in a patient whom you have treated so vigilantly. Why we are discussing about delirium today is because the significant amount of disease burden we have. Around 30 to 60% of patients who are admitted to an intensive care unit, they tend to develop delirium at some point during their ICU stay. And this incidence could probably increase to 80% in patients who are on mechanical ventilation. It is definitely associated with a prolonged ICU stay, a prolonged hospital stay, increased mortality, long-term disability, and cognitive impairment. Now, most of the studies, or as clinicians in ICU, we always look at mortality, we always look at ICU stay and hospital stay. What we don't tend to address is what happened to the patient once he got discharged and he went back home. What was his quality of life? Was he able to get back to his work? And I think that will be the defining factor, and that will be the deciding factor. It's not about getting the patient out of the hospital, it's about getting him back to work or back to the same quality of life what he had before he was admitted to the hospital. And it's not just about the patient but about the family as well. um, Although I'm an intensivist, but I've had a personal first on experience with one of my loved ones who was in ICU, was restrained, um, used to get really agitated with all the tubes and pipes in. And I'm sure as a family member, it did affect me and it did cause a little bit of stress. And I can agree to the fact that post-traumatic stress disorder is as common in the family members who see their patients struggling and agitated in the ICU as it is for the patient itself. So definitely look at long-term disability and cognitive impairment, which is very much an aftermath of delirium in ICU. So it does affect your survival. It so it is affecting it carries an increased risk of death whilst in ICU. What is delirium? It's an acute confusional state. It's a disturbance of consciousness, largely two components. One is inattention, and the other one is disorganized thinking. So the patients tend to have a reduced clarity of awareness of their environment. They have a reduced ability to focus, to sustain, or to shift attention. Commonly, we come across confusion, disorientation, impaired recent memory, lethargy, apathy, anxiety, stupor, coma, agitated. So there's a whole range of manifestations a patient can present with delirium. They may have hypersomnia, they may have disturbance to sleep-wake cycle, hallucinations, paranoia, delusions, fearfulness, withdrawn, they may be quite apathetic, uncooperative, use of fragrant language, and inappropriate behavior, irritability. So all this sounds very, very common to us. We usually see them whilst we are doing our ICU rounds, but do we really address them, or do we really treat them as delirium, or do we just ignore them, saying probably this patient has a subarachnoid hemorrhage, or there's a stroke, or there's a traumatic brain injury, and possibly this is a side effect of whatever illness he came in with. So as DSM-5, delirium requires for diagnosis disturbance in attention and awareness. That disturbance should develop acutely and tends to fluctuate in severity during the course of the day. There should be one additional disturbance in cognitive function. They do not occur in the context of a severely reduced level of arousal or coma, and there is evidence of an underlying organic cause, or maybe more than one. You can have different varieties of delirium in ICU. Patients can be hypoactive. They will appear to be quite apathetic, disinterested, and as the name suggests, it's very difficult for us to spot them whether they are suffering from delirium. Hyperactive, it's an abnormal mental state which is recognized with a hyperactive, aggressive behavioral pattern. They are not often recognized as delirium, and very commonly, nurse-based practice, we just go upon the sedation. Mixed delirium, this is a more common form of a delirium which you encounter. The patient may be aware of what is going on, but may also have episodes intermittently where they become disoriented. The patients tend to fluctuate in and out of hypoactive or hyperactive delirious state, more common at the end of the day. Now, I love this analogy while I was going through the literature, as in delirium should be treated as an organ dysfunction. And why not use an analogy to an acute kidney injury? So when the patients come to ICU, we often tend to identify them at a very early stage that this is somebody who's predisposed to develop a kidney injury. So he is a patient who's at risk. We tend to do things which are not nephrotoxic. We tend to avoid nephrotoxic drugs, contrast, nephrotoxic interventions. We try to be on the top of things, regular monitoring of urea and creatinine, regular monitoring of electrolytes, and we tend to early intervene to avoid acute kidney injury or patient going on a dialysis as far as possible. Now, why can't we use the same analogy when it comes to delirium to identify the patients on admission that this is somebody who's potentially at risk of developing delirium? This can only be done when we know there are certain risk factors which are associated with patients developing delirium, or patients are more likely, this category of patients are more likely to develop delirium. To use interventions which would then lead them not to develop delirium, and again, regular monitoring, regular screening, and early intervention. Now, after having said that, I know more our audience today is the trainees from neurointensive care, my colleagues from neurointensive care. As clinicians, we always tend to, so we are fond of prescribing drugs, and we always look at pharmacological methods. But I think the key to deal with delirium in ICU is training your nursing staff, trusting your nursing staff, making them more confident, because they are the ones who are going to spend most of their day with the patient. They are more likely to identify patients who have delirium or are at risk of developing delirium. So I think good nursing care, educating them, and simultaneously being open to the idea that yes, my patient, although he has an underlying brain dysfunction, but a recent change in his mental capacity or in his mental status could mean delirium, and it's not a part and parcel of his traumatic brain injury or his subarachnoid. Risk factors. So there are certain predisposing factors like old age, dementia, functional disabilities, a high burden of coexisting conditions, male sex, poor vision and hearing, lab abnormalities, high urea and creatinine, acidosis, and alcohol abuse. um, Predictive models. Now, this is a very easy online calculator called as pre-deliric, which enables the physician to predict delirium within 24 hours after admission to intensive care for the complete stay in intensive care. Now, this model facilitates early identification of high-risk patients and targeted early initiation of preventive measures. It consists of 10 risk factors, including age, Apache score, what was the reason for ICU admission? Was it a medical reason or was it a surgical reason? Was it an elective ICU admission or was it an urgent ICU admission? Is the patient comatose? Are the opioids being used for pain management? Um, Apache score, as I said, and presence of metabolic acidosis, and what was the patient's blood urea. All these parameters would definitely be available within 24 hours of admission. So if we make it a practice to screen all our individuals, all our patients who are admitted to ICU with a pre-deliric score, we would know that possibly this is a subset of patients who are more likely to develop delirium. So we want to be on the top of the things from before end. So this is something which can be done at the bedside, doesn't need more time. It's a simple online calculator. Uh, Now, management is just not treatment, but management includes recognition of the problem, identifying the risk factors, what can be done at the bedside, and thereafter treatment. Now, delirium, although we say it's a single entity delirium, but it involves lots of ongoing things. In my hospital, in my trust, and otherwise in UK as well, we follow something called as PAD guidelines, which is pain, agitation, and delirium, because we believe all these entities are interrelated. So delirium doesn't come as an individual, but it is always related to an underlying cause. It could be pain, it could be agitation because of some other reasons. Now, when we start screening or when we start assessing the patient or managing the patient with delirium, the first thing is to look at, is there any underlying pain? Uh, Now, our patients would be intubated, they'll be sedated, so you can't use normal scales of pain assessment. So you need to have some ICU or dedicated pain assessment tools. We commonly tend to use a behavioral pain scale or a critical care pain observation tool. Again, very easy to use, very handy, can be used by the nurses at the bedside. So what we tend to do here is prescribe opioids and non-opioid medications as PRN or SOS basis. The nurses tend to do a repeated pain assessment scoring on these patients. They're usually done twice in a shift. And however, irrespective of the regular assessments which are done on chart, if the patient does manifest symptoms or signs which look like as if patient could have had pain in terms of their facial expressions or their ventilator asynchrony, the nurses are promoted to use pain medications or analgesia as and when required, because pain is one of the most important predisposing factor which makes patients uncomfortable, interferes with their sleep wake cycle, and ultimately leads them to develop delirium. So again, Please use these tools, and please encourage your nurses to use these tools. Very handy and easy to use. So, behavioral pain scale and critical care pain observation tool. After you know or you're satisfied that your patient is unlikely to have pain or you've treated the pain, the next thing is to assess their level of sedation. Now, depending upon why was the patient admitted for and what are you dealing with right now, you will have to tailor or titrate your sedation to achieve a dedicated value of RAS. We don't believe in something called as end of the bedogram. You can't make assessments standing at the end of the bed and saying this patient is not delirious. You need to interact with the patient. You you need to see the parameters, you need to see their expressions, you need to see their ventilator synchrony, you need to try to waken them up, to arouse them, to assess them. So please don't believe in end of bedogram. Use these scales and use these parameters. After you're sure that the patient's pain has been taken care of, we assess the sedation. Now, again, in acute stages, when we're dealing with traumatic brain injury, or a neuro ICU, when you have somebody who might be having a raised ICP, you would not be um, looking for a RAS of 0 or 1. You would definitely be keeping them well sedated to avoid any triggers in their ICP. However, again, reassessing them daily or reassessing them in every shift to give them spontaneous awakening trials and spontaneous breathing trials is the key to early rehab and early getting back to their normal stage. Um, we use RAS or Richmond Agitation Sedation Scale. Again, it is one of our columns on our daily nursing charts where the nurses monitor the RAS score twice in their shift. Again, as a clinician, when we are assessing the patient, we redo it to cross check that the RAS score is what we have, we would want from that patient. We normally, again, we have a mixed ICU, so it usually depends on what are we looking at. So in traumatic brain injuries, in the early days, we would try to keep it at -3 and -4. However, once the pathology is settled, their hematomas are evacuated, the ICPs are no longer an issue, we try to then relax our sedation practices or sedation schedules to get them to a RAS of 0 and -1, depending upon where we are. So, again, assessing them on the bedside with a RAS scale and tailoring your sedation to a particular aim. So if you give clear indications to your nurses as I would want my patient to have a RAS of -1, or I would want my patient to have a RAS of -3, it's very unlikely that your patient is either over sedated or under sedated because they have clear instructions and they know what they are aiming for. Uh, Once you have assessed your pain and once you have assessed your sedation, the next thing is to now screen the patient for delirium. Uh, as far as ICU settings are concerned, we use CAM ICU and ICDSC scores to assess our patients for delirium. Now, CAM ICU comes as a very handy tool. This is what I normally do in my clinical practice, and most of the trusts in UK follow the CAM ICU score. Again, something which both nurses and clinicians can use. It has got 4 questions. The first one is you need to identify that there has been an acute onset change in patient's mental status. It's different from the baseline and it's fluctuating. Now, having said that, it's very easy to say it's there is a change in the mental status from the baseline. But in a neurocritical care setting, it's very difficult to identify what was the patient's baseline. Your patient comes with a traumatic brain injury or your patient comes with a stroke. Um, you don't have a baseline there, and you can't identify a baseline. However, having said that, if your patient was being given a spontaneous awakening trial and he was somebody who was trying to follow commands, although he was hemiplegic, but trying to do something. But there's an acute change from in last 6 to 8 hours. It is delirium, and it is something which needs to be addressed. So if your nurse reports that this patient is now behaving abnormally, which he wasn't until possibly 4 hours or until her shift started, it is something to be looked into. It could be delirium. So, is there an acute onset of change in patient's mental status, and it is fluctuating? The second and a very important component of delirium is inattention. How to assess inattention? We do something called as an attention screening examination. And hallmark of delirium being that they tend to shift or change their focus from one thing to another in a short span of time. So they're not attentive. Now, this can be judged again by using simple bedside assessment tools. We tend to ask them to squeeze our hand whenever we say the letter A. So you can use a mnemonic, save a heart, and they're allowed to make 2 errors. Now, again, this can be tailored to your circumstances or your ICU setting and your language, but it's just about looking at, is the patient attentive or is the patient following what you are asking them to do? A simple thing, just ask them, squeeze my hands whenever I ask or whenever I raise a letter, again, maybe from Hindi, Tamil, Kannada, whatever language we use with our patient or whatever language the patient uses. It's about assessing how attentive they are. The third one is disorganized thinking. Again, there are subset of questions and commands here. You ask them some questions like, do you think fishes fly in air? Or do you think if you put a brick in water, is it going to float? So this is analyzing how organized their thinking is. So you have two components in this, a question sequence and a command sequence. A question sequence is where you obviously ask these questions, where you are making them think, is it possible? Do you think this is possible? Do you think a fish can fly in air? Do you think... So you're trying to analyze how much or how deep can they think. And the second component is giving them a command. So we normally ask them, if you could raise 2 fingers from your right hand, you can show them this time. And if they're able to do it, you ask them to repeat the same task from the other hand, but you don't show them this time. So what you do is, can you please lift your fingers from your right hand? Yeah, you've done that. Can you repeat this task from your left hand? So you're actually making the patient think, okay, this is what I did. I raised my 2 fingers from right hand. Now he's asking me to do it from the same exercise on my left hand. So you're actually making them think. You can tailor this approach to your patient if they have hemiplegia or if they have monoplegia, by asking them to increase the number of fingers on the same side. So if the patient raised 2 fingers this time, just ask them to do, can you lift 1 more this time with the same hand? So you're again kind of making them think, okay, this is the command which has been given to me, and so he will use his analytical thinking and try to do it. The fourth component being altered level of consciousness. You would have anyways done it already. So a RAS of anything less than 0 is definitely altered level of consciousness. However, if your patient is alert, he's unlikely to be delirious. The key is reassessment, and documentations. They can vary from assessment to assessment. Reassess at least once a shift. That's roughly around every 4 to 6 hours. It does form a part of clinicians as well as nursing assessment. You need to document so that you have a trend as to how was the patient doing before. Was he CAM ICU negative, or was he CAM ICU positive and he's become negative now? This is something which has to be reviewed on ward rounds daily, and your nurses and your nurse in charge should be available that this is a patient who's delirious. This is a patient who's likely to be unsafe for himself and for his surroundings. They need to be aware because of nursing allocation. These are the patients who need more nursing care. You can't obviously compromise them by giving a nurse 3 delirious patients, and then she's struggling amongst 3 of them, ends up increasing sedation for all of them, and this is not what you would want as a clinician. The next scoring system is ICDSC, where you have 8 items, starting from altered level of consciousness, inattention, disorientation, presence of hallucinations and delusion. Is there psychomotor agitation or retardation? Does the patient have inappropriate speech or mood? What's his sleep wake cycle? Is it disturbed? Are his symptoms fluctuating? Now, again, having said about sleep wake cycle disturbance, what we tend to maintain is something called as a sleep diary, where we kind of monitor what is the so how frequently is the patient sleeping? Is he sleeping at a stretch for more than 4 hours? This is what you would want, or this is what sleep hygiene is, because again, it is very important to maintain to avoid delirium, which is one of the risk factors. So we tend to maintain something called as a sleep diary. Now again, ICDSC, pretty straightforward. You need to give a score for all of them. There are dedicated charts online. You can use it and tailor them according to your needs. While I was just reviewing the literature, so we tend to use CAM ICU score, I think 95 to 100% time in my ICU setting. And my ICU is a mixed ICU where we tend to get both neurological patients and general patients. We use the score for both of them. However, while I was reviewing the literature, it did mention that ICD-SC is something which is more validated, is more reproducible, is more specific and sensitive when it comes to CAM ICU score in neurological patients or critically ill patients. Again, I think because of the fact that we're using speech, we're using hallucinations, and we're using psychomotor agitation as a part of assessment in ICD-SC. When it comes to treatment, again, treatment or management of delirium does not mean pharmacological management. It's a holistic approach. It involves bundles of care. You need to have dedicated guidelines. You need to have ICU-based or tailored approach. Your nurses should be well educated. They should have the confidence of assessing the patient's bedside, of raising alarms, as in this is the patient who's probably delirious. This is the patient who needs treatment. We tend to follow something called as a A to F bundle, where A, B, C, D, E, F has a dedicated label, and we tend to tick mark that these are the things which are being followed. So is the patient being given spontaneous awakening trials? Breathing, so you tend to liberate them from mechanical ventilation as early as possible. Treat hypoxia, treat respiratory failure. How are they hemodynamically? So C is for circulation. Do not let your patient dehydrate. Avoid use of diuretics if they're not indicated. Furosemide is one of a common drugs associated with delirium, often overlooked upon. Try to keep your patient well hydrated. If your patients are well hydrated, they're less likely to be agitated, they're less likely to feel thirsty, and of course, they're not going to be the ones who are going to come up front and tell you. They're less likely to develop bed sores, maintain a decent skin integrity, which is again one of the reasons why patient could be in pain, or patient could be agitated, or patient could be uncomfortable. D's again for your sedation scores. Do proper screening, use proper screening tools, use your RAS, use your CAM ICU. So follow a to F bundle. Again, PADS. So we have pain, agitation, delirium guidelines, which again, these are very handy guidelines. So the nurses can make an assessment. And so again, why I emphasize on nursing is, one, UK is a very nurse-led ICU. Lots of decision making is done on the floor by nurses. Uh, However, having come here, and I've worked in neurocritical care in India, and I moved to UK, so I've seen both the subsets. And what I really feel is, what we lack back home in India is a proper nursing allocation. So we do tend to struggle with good amount of nurses, which ultimately compromises the care of the patient. And dealing with pain, dealing with agitation, dealing with sedation, it is something which is done on a regular basis. So you as a clinician coming for ward round, seeing the patient, again, end of the bedogram, seeing the patient for 5 minutes, this is not going to help the patient. So your nurses need to be trained, need to be educated, need to have the confidence to use these guidelines, to use the medications which have been prescribed on as and when required side of the prescription chart, to make an assessment that this patient is in pain and not agitated. So he needs analgesia, he needs paracetamol, he needs opioids, or he needs analgesia for neuropathic pain, but he doesn't need to have increased sedation. So she doesn't end up increasing propofol, she doesn't end up increasing midazolam infusion. So they need to be educated. You need to have proper pain, agitation, delirium guidelines. This is something which needs to be done when patients show signs of pain on assessment on behavioral pain scale or CPOT. This is something which needs to be done when the patient's agitated, at risk of removing his lines, pulling out tubes. And this is something which needs to be done if patient is delirious. Again, early intervention is the key. You need to identify the patients who are at risk, screen them for risk factors, use scoring system, pre-deliric online calculator is the one which we can use. Prevention and management, keep them well hydrated, keep them pain-free, maintain a decent sleep-wake cycle, maintain a good sleep hygiene. Visual and hearing aids, we often again don't tend to address these factors. I think it's now, this is again my experience from NIMHANS, because I did my neurocritical care from NIMHANS. Um, every morning, the nurses would play Suprabhatam in the neurosurgical and neuromedical ICU. Now that was something which used to just awaken us, has a very feel good factor, and I'm sure the patients who are there would definitely feel divine, or would definitely have a good feeling if you play something which they are able to relate to. And I remember our consultants, especially Uma sir, would tell us, let the families bring some music aids, or let them bring some small radio or something to let to let the patient have that hearing or hearing experience, um, to let them overcome this atmosphere. So I think emphasizing on giving the right visual aids, to give them the right hearing aids, uh, make the families aware, especially again if you're dealing with patients like myasthenia and GBS, who don't have an acute brain issue, but it's largely a muscular issue. You are dealing with them in a neurocritical care setting. They are very much the patients who are awake, who are seeing things happening before them. Uh, Try to get the families involved from an early stage. I think we should have much more liberal visitation policies, because the patient who was a urgent admission to ICU, or who was an emergent admission to ICU, maybe he's not even aware that he's in ICU. I think having families bedside, having families speak to the patient, to hold their hands, to tell them that they are in safe circumstances, that possibly this is what was something which happened to them, and now they are safe, they're recovering, they're making the right progress, is something which is very reassuring for the patient. And I think we should allow more liberal visitation policies. We should have more family members involved in patient care. Do you think your patient is more confused than normal? If yes, then think delirium. It's a very common acronym we use here. Delirium, D stands for dehydration, as I already said. Maintain hydration of the patient. Give them visual aids. Ask the families if they use spectacles at home to get the spectacles, if they love reading or if they want to have a newspaper. Especially patients who are on your neuromedical side, who are intact from their brain perspective. Let them have some visual aids. Again, this involves a lot of financial implications as well. But if your ICU is capable of, try to get some visual aids. Uh, we tend to have big television monitors wherein patients can switch and can they have the choice of watching what they want on television, so they don't end up seeing the chaotic ICU atmosphere around them and get delirious. Again, if you allow them to use more and more visual aids in the daytime, they're less likely to sleep in the day and maintain a good sleep hygiene. So that is something which should be looked into. Getting hearing aids, if they use, especially with elderly population, you might not be aware. This is something again to be asked with the families, that was this patient using hearing aids before? Is it something they can get from the home, and try to use it as early as possible. Are you restricting the mobility of the patient? Is it something which you can look into? Sorry, again, physiotherapy and rehab is something which needs to be inculcated in the practice from very early on, especially when you're dealing with stroke patients and patients with traumatic brain injury. Uh, Let them be mobilized early. They will have pain issues. Please deal with their pain issues, but don't compromise their mobility. Allow them to be mobilized. Um, Allow them to be taken outside the ICU. If if the patient's ongoing tracheostomy wean, if they're ongoing tracheostomy mask trials, I think they can well be moved outside the ICU with the family, with the physiotherapist and the nursing, so that they come out of their usual ICU atmosphere in open air. So we tend to have something called as garden rounds or garden policies. I'm sure again there's a lot of staffing uh, which needs to give us support when it comes to moving patient outside the ICU. But again, it's something which helps the patient. So if we are looking at long-term financial implications, I think if we employ more physiotherapists and more rehab therapists which are involved in patient care, we definitely would be able to reduce financial implications, which comes with a long ICU stay, acquired ICU infections, especially resistant infections, and the antibiotic cost. So this is again something to be looked upon by um, people sitting on managerial posts as to what are the investments that need to be done when it comes to dealing with rehab, giving the right mobility or rehabilitation. Dealing with infection, reducing pain, impaired cognition, up at night, do not let them be up at night. So we try as what we try to do is deliberately make them tired in the daytime by giving them, so it's not about exhausting them, but try to club your trachemas trials or your weaning trials more so in the early part of the day. So by the end of the day, they usually tend to get more tired and then tend to get more sleep, to allow them not to fall asleep during the day hours. Again, nursing comes here. Uh, so I think as clinicians, we need to identify delirium is a lot about having a good nursing care. Again, looking up at medications, not just at what you need to give them to treat delirium, but as well looking at the drug charts, to see what we should not be giving them. So if they don't need opioids, please strike them off. Don't give them benzodiazepines. It is not something which is going to help you. It is just going to make you comfortable, having seen a patient who's calm and quiet, but you would end up having a more delirious patient 3 days later. So please avoid benzodiazepines. Avoid furosemide, avoid steroids, avoid few subset of antibiotics, quinolones being the most notorious for causing delirium. So do look at your drug charts. Please strike off the drugs which are no more needed. Again, when it comes to delirium, discuss and agree a treatment and a management plan. Tailor your management plan to your ICU setting, to your patient setting. Do treat the underlying or the precipitating cause. It could just be simple pain, it could be hypoxia, it could be acidosis. Promote normal sleep-wake cycle. Treat hyperactive agitation with drugs. Review sedation on a daily basis. You don't need to keep the patient sedated for all his life. You need to give them awakening trials. You need to give them breathing trials. Only use benzodiazepines if alcohol withdrawal. Again, I think I forgot to mention alcohol is one of the most notorious factors. And again, not just alcohol, smoking, which we often tend to ignore. Uh, you never know, your patient who was admitted with a traumatic brain injury was actually driving under the influence of alcohol. So he was consuming alcohol just till the time he was admitted to the hospital. Now, 3 to 11 days is a very critical time where he could show signs of withdrawal. Uh, if this patient ends up being agitated, becomes unsafe, at risk of removing his lines, at risk of removing his tubes, and you end up increasing his propofol or increasing his midazolam and morphine, thinking, oh, probably this is a subarach or a traumatic brain injury related delirium, whilst actually it was just simple alcohol. So I think from very starting on, you need to find out with the families what is the patient's habit like. Is he somebody who is habituated to alcohol? Is he somebody who is habituated to smoking? Do you need to put withdrawal policies or alcohol withdrawal treatments in place? We use something called as a SIVA scoring, uh, which again, the nurses do a scoring system based on whatever the scores are. They are free to administer closed diazepoxide, or they are free to administer benzodiazepines so as to avoid any alcohol withdrawal. Be liberal with nicotine patches. Smoking is one thing, again, with which patient can land up into withdrawal. Again, no single pharmacological agent can prevent delirium. No single pharmacological agent can prevent a brain dysfunction, and it is necessary to actively monitor for delirium and pay attention to the details that may put the patients at risk for delirium. So, if you look at literature, there have so there's a whole lot of literature focusing on prevention of delirium with drugs, and there have been trials using haloperidol, there have been trials using dexmedetomidine, there have been trials using statins, but none of them have shown a significant benefit, although they do. So some do tend to decrease the incidence of delirium in the ICU. But in terms of a long-term ICU stay, in terms of a mortality benefit or survival benefit, none of these medications has shown a significant future in terms of prevention of delirium. So HOPE ICU was one of the double-blind, placebo-controlled randomized trial in which they used 2.5 milligram of haloperidol versus placebo every 8 hours in patients who were on mechanical ventilation within 7 hours of admission. Now, this was largely aimed at looking at prevention of delirium or the onset of delirium. However, they didn't find any significant benefit out of it. What are the drugs which we commonly use in delirium? Haloperidol, olanzapine, risperidone, quetiapine. I personally have a very good experience with quetiapine. The only problem being looking at ECG for a prolonged QT interval. You need to start at a low dose, especially in elderly population. You can up titrate it as per your response. Again, once these antipsychotics are started and you start looking at a desirable response, please don't forget to stop these medications. Patients do get discharged to ward and then subsequently to their house or to a rehab center or whatever discharge facility it is, and these antipsychotics are carried on. So please review them once you have started as to when can they be stopped. Dexmedetomidine, again, I think it's one of a very commonly used drug for delirium in ICU. Again, here in UK, we don't tend to use too much of dexmedetomidine because it it comes only as an IV formulation. It doesn't come as an enteral formulation, and there's a significant cost factor associated with it. So what we tend to use is clonidine. I've, I've used clonidine both in neuro critical care and both in general ICU patients. We have a very good experience with clonidine. We extubate patients whilst they are on clonidine. You don't carry the risk of respiratory depression. They remain quite calm but arousable. They remain quite interactive. The only problem being bradycardia and hypotension, so which might not be desirable, especially in patients with traumatic brain injury. So that's something which has to be looked upon before you start them on clonidine and dexmed. But personally, I have a good experience with with clonidine. Um, I think that is it from my end. Have I made the audience sleep?
No, it was a very nice, informative presentation, ma'am. Thank you, Dr. Megha. So, like you said, ma'am, identification is a very important part, and many of our patients, especially the neurological patients, they have Parkinson's, so it becomes very difficult to distinguish between whether the
Yeah,
patient is having delirium or that is the baseline status. It becomes very difficult to identify.
yeah,
And
and
it is
yeah, and I think as I said, and as you said, of course. So whatever screening tools I've just told, or whatever assessment scores we have, they have all been validated in a general ICU setting. And it becomes very challenging for us as neurointensivists to use in our setting where our patients will have an underlying brain dysfunction. So again, everything has to be tailored to your patient setting, and you need to be aware of, okay, probably this patient has an underlying aphasia, so I'm not wrongly labeling him as hypoactive delirium when actually he was aphasic due to his stroke, or he's hemiplegic, he's not squeezing my hands, but he's not squeezing my hands not because he's delirious, but because he's hemiplegic. So that is something which we need to be aware of and keep telling us when we are dealing with neurocritical care patients.
exactly, ma'am. So I think nowadays many trials are there. I mean, they have even tried modifying the diet. Recently, there was this mind trial, I think, ma'am,
Yeah,
where
yeah,
they were
yeah,
giving the Mediterranean diet plus the DASH diet,
yeah,
which
yeah,
is the diet to prevent the hypertension also. And they
yeah,
found that the cognitive scores mildly improved, but I think like more information needs to come from there.
yeah.
And there is another trial, ma'am. I mean, I was just for this topic, I was just going through different trials which were there. So there was one mental trial where
Oh,
they have mobilized the patient, where they have
yeah,
mobilized the patients in the evening, ma'am, between 7 to 9 o'clock, so that the
mhm,
patient becomes tired and they go
yeah,
to sleep. Like
yeah,
you stress the importance of a very good sleep. So
yeah. Yeah, and that's what even we try to encourage here to. So it's not about exhausting them, but actually trying to do more ex so more trachyvine trials or more spontaneous trials, so everything in the daytime and not letting them sleep, because of course the patient doesn't have anything else to do. So if you don't involve them, they tend to fall asleep, and this
correct.
then reciprocates to them not having a good sleep wake cycle and then being awake whole night and becoming more delirious. So yeah, I think sleep wake cycle, maintaining a sleep
That's
diary,
very,
good
yes.
sleep hygiene. Yeah.
Ma'am, so you mentioned about two different types of delirium, the hypoactive and the hyperactive.
Yeah.
So the hyperactive, yes, we do give Serenus or quetiapine and we try to calm them. But how about this hypoactive delirium? Is there any maneuvers for them
So
or
I think,
medication?
yeah, so as far as hypoactive delirium is concerned, I don't think we have any pharmacological interventions to be made here. But in fact, assessing why the patient is in hypoactive, is it something which we are doing to them? Are we over sedating them? What is their RAS score? What was the RAS score which was aimed at? Are we overachieving our targets? Is the patient in significant pain and now he has become exhausted and become more hypoactive? Is the patient dehydrated? And I think, again, in neurocritical care setting, it is very important to rule out a non convulsive status epilepticus here. So, if your patient is not engaging, if your patient is apathetic, if your patient's deeply sedated when actually you're not giving them any sedation, this could be hypoactive delirium, but at the same time, try to rule out a background non convulsive status epilepticus. So, if your EEG report comes as there's a generalized slowing, predominant theta activity, it is likely to be delirium. Rule out metabolic parameters, rule out uremia, rule out hyperammonemia, rule out withdrawal. Is the patient hypoactive because actually he is used to having alcohol, which he isn't, of course, got here? So I don't think hypoactive delirium is something which needs pharmacological interventions. But in the first place, it is something which needs identification because we standing at the end of the bed, it is very easy to recognize somebody who is picky, who's very fidgety with his lines, trying to pull out tubes, is more likely to receive therapy, is more likely to receive attention. But a patient who is just hypoactive, not engaging, is more likely to be overlooked and ignored. So I think, as far as hypoactive delirium is concerned, the most important factor here is identification rather than treatment.
Correct, ma'am. This EEG part is a very good point. We have to rule out NCSC by doing an EEG
Yeah,
in a hypoactive delirium. Very true, ma'am.
yeah,
So I would like to conclude the talk by just recapping few important points. A very important point is we have to know the baseline of the patient. We have to ensure that we identify the patients who are having delirium, and we have to promote good sleep. We should prevent unnecessary immobility. We have to mobilize the patient and give a good rehab. And we have to identify whether the patient is having any visual or auditory impairment and help the patient accordingly.
yeah,
And very importantly, give a good diet and avoid dehydration.
yeah,
And use
yeah,
all the skills to, identify it. And like ma'am said, a nurse-driven program would be better in identifying delirium and treating the patients effectively.
yeah, yeah.
Thank you,
Um,
ma'am, so much for this presentation.
and thanks to you for not, so when you summarized, for not using pharmacological methods, um, because as clinicians, we are fond of writing medications on the drug chart.
Medication.
I think that should be the last resort. So please, please, please don't write medications in your drug charts when they're not needed. So, and just to add on to one more thing, it is something which needs a team management, not just a clinician management. You need a team to treat delirium. You need good nursing care, rehab, physios, dietetics yourself. So it is a team approach.
Definitely, ma'am. It's a team effort. Okay, ma'am. Thank you so much.
Thank you. Thanks
So
a
we'll
lot.
be, thank you, ma'am. So we'll be back after another 2 weeks with another topic for presentation. Thank you so much for viewing. Thank you.
Yes, thank you.